Thank you. Welcome, everyone, for joining us today for MVC's Health and Action Work Group. My name is Emily Bear, and I'm one of the site engagement coordinators with the Michigan Value Collaborative. It's my pleasure to be facilitating this work group for you today. All right, so our agenda for today's work group, we're going to go through a couple of housekeeping items and reminders. Then we'll hear from Doctors Janke and Schmitzberger, I'm going to get that, of Michigan Medicine's Emergency Department. They're going to be speaking on their work in developing feedback loops for emergency care enabled by AI. Very in the news right now. So I'm excited to hear from them on this really new work. We'll then follow up their presentation with a chance for discussion and questions. I'll be monitoring the chat along the way, but I'm going to try not to interrupt their presentation. And then lastly, we'll review a couple of upcoming MVC events and reminders, and we'll finish out for today's work group. So those housekeeping items are just noting that we are going to be recording the session, so please keep yourself muted unless you want to unmute to ask a question during the discussion portion of today's presentation. And then for questions, like I mentioned, I'll be monitoring the chat, but we will save all of those to the discussion portion. For those that are attending today's work group for P4P credit attendance, we will look forward to your active participation through the chat and discussion. And we will also share that post-work group survey at the end of today's work group. The link will be shared in the chat as well as in a follow-up email. Completion of that survey is required to receive credit for your attendance to today's work group. All right. So today's presentation is going to be led by Drs. Janke and Schmitzberger. Alexander Janke is an assistant professor of emergency medicine at the University of Michigan, affiliated with the Institute for Healthcare Policy and Innovation, the Michigan Institute for Data and AI in Society, and the Michigan Emergency Department Improvement Collaborative. Dr. Janke is working to make emergency care safer, higher quality, and lower cost in the US. Welcome. And then Florian Schmitzberger is a clinical assistant professor of emergency medicine at the University of Michigan, affiliated with the Max Harry Wheel Institute for Critical Care Research and Innovation. With formal training in biomedical computation and bioinformatics and fellowship training in resuscitation science, his work focuses on cardiac arrest, physiology-guided resuscitation, clinical informatics, and the use of emerging technologies to improve emergency care. Welcome as well. All right. I am going to now pass the torch over to our presenters to present on Tell Me What Happens Next, a feedback loop in emergency care enabled by artificial intelligence.
Thank you
Just
so
let me know when
much.
you want me to progress, Alex.
Oh, will do. Thanks a lot for the kind introduction. We're really excited to talk to all of you. Florian and I are humble emergency medicine docs, but we care a lot about quality improvement, and many of you in this room have line of sight on quality improvement, and I think we're really excited to get some feedback from all of you. Next slide. We are supported by the Michigan Institute for Clinical and Health Research and the University of Michigan Medical School Office of Research, specifically Dr. Lou Edgy, who is Vice Dean for Medical Education at the medical school. Next slide. We'll tell you about why frontline clinicians need help to better understand their patients' journeys and the influence in the path that patients take that we have. We want to describe at a high level how artificial intelligence and specifically large language model enabled feedback can work and what the workflow integration literally looks like. We'll tell you about uptake and performance so far at Michigan Medicine Adult and Children's Emergency Services, and truly the wind in our sails on this project right now is just how popular this is with our docs and PAs. And then we'll tell you about where we think we can go from here. why we believe this simple workflow can be a breakthrough for engaging frontline clinicians in quality improvement. And we hope to get, like I said, some feedback from all of you about what next steps could look like. Next slide. So, as background, in the next slide, I want to tell you about one of the really popular maneuvers in emergency medicine, the central line placement. It's a core procedure in emergency medicine, it's a core competency, and it's one where the feedback on how we do is immediate. So, when I set up a patient to place one of these large IVs in the groin or the neck, I talk the patient through it. I carefully inject lidocaine under the skin to anesthetize the area. I place this large catheter into the vein in the neck. I pull back the blood on the port. I see that blood fill the syringe. And when I get my chest x-ray and I see that catheter sitting down in the superior vena cava, I know immediately, I have this very tactile feedback on the quality of the care that I've provided that patient. And although it's rare and we should mitigate with every effort complications from central line placement, we do get immediate feedback when we thread that catheter up towards the head instead of down towards the heart on our chest x-ray. And that feedback very much is part of developing expertise in emergency medicine. Next slide. A few years ago, I met a really nice lady who was struggling with double vision. She'd been seen by a couple of outpatient docs. She'd been seen by a primary care doc in one visit with a non-specific presentation of neurological symptoms. She was struggling to get a diagnosis. I did a really careful history and physical exam. I did a bedside test on her. I had a very strong suspicion for the suspected diagnosis in this case. Um, and I did some neuroimaging and I tried to point her to the right next step, which was some additional testing that would take a few weeks to come back and a neurology follow-up appointment. Now, as it happens, this particular diagnosis is one that can occasionally be made in the emergency department, but is often something that takes days, weeks, and rarely even longer for folks to really get on the right path with. The neurologist that followed up on this patient happened to be a personal friend of mine. And so I got that feedback. I found out from him, he was able to follow up on the case and I think had that patient in clinic just a week later, and she got great care. But many times we actually don't get that tangible feedback on how things went for our patients. We do our best to adhere to best practices, but actually tying our efforts at the bedside to the full scope of a patient's journey is really difficult in emergency medicine. Next slide. One of the really important sort of models for clinical learning, and this is drawn from the medical education world, is called the Master Adaptive Learner Cycle. And so it describes how when you're up and coming as a clinician, you sort of move through these stages of planning, learning, assessing, and adjusting. You make a plan for how you're going to learn on shift. You assess how you performed, and then you make adjustments. And it's really quite easy to make that assessment when you're working with your resident on a central line placement. But when you want to do that assessment phase on diagnostic practices for rare conditions, ones where the final outcome that really matters to the patient could be weeks away, that learning cycle can be broken. Next slide. The problems with the learning cycle for individual clinicians who play just one small role in a patient's journey are numerous. This can contribute to practice variation. Practice variation is not just about differences in case mix or differences in resources or skill, but it also represents genuine clinical uncertainty, lack of clarity about our role in patient care. It's a missed opportunity for learning and one where the stories match the data and make it easier to learn. And then it's a blind spot for quality improvement. So dashboards alone sometimes don't reflect the complexity of the work that we do. Summative numeric measures of quality don't necessarily always make contact with the day-to-day decision making that we do. And without this case level review for individual clinician, tying the data to the stories, metrics can accumulate, but the stories to actually motivate change won't land. Next slide. And so the old way was manual chart review. The old way was self-imposed in-basket reminders or word-of-mouth follow-up, the dreaded tap on the shoulder from a colleague asking you if you remember that patient from a few days ago. Large language models can be applied for this very simple task of reviewing and summarizing clinical care, tailored towards a focus on the emergency medicine context. And this is an example of how AI can help humans learn rather than using AI as a stand-in for human expertise. Next slide. So I'll hand it off to Florian, who's going to tell us about sort of how we did this and the engagement that we've had so far.
Fantastic. Thanks so much, Alex. All right, let's move to the next slide, please. So this is, broadly speaking, how we actually manage the pipeline of bedside to receiving your summary. So during the patient encounter or afterwards, the clinician can decide, hey, I'm interested in how this patient does. I have a question about this patient. I'm curious about this patient. And Alex already talked to us how the old way worked, where you basically had to like add your patient to a list, write down the number, remind yourself of that. In this case, I'll show in a second how the marking of the patient works. You then wait. That one's non-optional. You have to wait for a couple days, up to 2 weeks in our current setup, while things happen to the patient, or hopefully don't. After that, you receive an AI summary. So the AI summary gets generated using, in our case, the GPT toolkit, which is a HIPAA-compliant large language model. This can also be done via local models. This can be done with anything that allows a protected healthcare information to be processed using a large language model. Um, you then receive an email in your inbox. This has the identifier, basic information on the patient, and those summaries, and then you're able to reflect on that patient. Next slide, please. So, how do you request the information? In the emergency department, there's a branching point in our decision making, which is the disposition, where we basically decide, hey, that patient's gonna go home or he's gonna stay. Oftentimes they stay a long time in the ED, but at some point, you gotta go home or you gotta stay in the hospital. And we, at that decision point, we decided would be the best point for our clinicians to request follow-up. So on the left-hand side, you kind of see a tell me what happens next button. This is next to a few other buttons that are commonly used. So it's like in view, but it's not obtrusive. And similarly, during the admission process, when we put in an order for admission, you have a button that says, hey, send me some follow-up on this patient. Now, clicking the button prompts allows you to enter some additional information. So it lets you select the time frame. We have pre-selected those based on the wishes of our colleagues and what we think is reasonable. And it also adds any specific question you want answered, meaning I am interested in, did those patients' blood cultures grow anything? Did that patient ultimately need antibiotics? In any case, you get a summary. But oftentimes I got a hunch of like something I want to know for sure. Um, did the patient return? Did the patient need an upgrade to the ICU? Oftentimes when I deal with a patient, there's a little nagging voice in the back of my head. It's like, I don't think this is going to happen, but I'm curious. So in order to reflect on my patient care, this is something I want to know. Next slide, please. So then at this predefined point in time, you receive a summary, and this is what it would look like. So this is, you get a little summary here. You get a reminder of who that patient was, a chief complaint, and a very basic summary. The summary in many cases is much longer. We selected, well, I guess, we made up a case that basically was very short and simple that we would see all the time, right? Like somebody with immunocompromise having an infection. Yeah, I really kind of care how they do because they're higher risk for complications and worse outcomes. So in this case, basically, the summary is produced, and underneath you can see you ask, did this patient come back to the emergency department? Return visit not documented. Only subsequent records of population health outreach call. That would make me feel a lot better, knowing that I discharged the patient, They did not have any more contacts with our healthcare system, and the learning cycle is closed for me at this point. Next slide, please. So we kind of realized, well, we think this is great. Us thinking this is awesome doesn't really buy us anything. We need to also validate to see that those summaries are actually uh, useful. So we had 200 AI-generated case summaries validated and rated on accuracy, conciseness, helpfulness, and completeness. And this has been a while ago, so these numbers actually are much better at this point. Specifically because we use them to adjust our prompting, our algorithm, and everything else. But even in the first iteration with an older large language model, they're really accurate. And the inaccuracies were honestly, we've since compared it to PA written summaries, and we're on par with them. So it's impressive, scary how good AI is at being accurate, concise, and helpful. We had very good results with this, and this kind of prompted us to move things forward with this project. Next slide. So here are a few of the puzzle pieces, the stakeholders that we required to get on board for the project itself. The big view for all of this is some of you listening in might be like, hey, how do I get this at my place? How do I make this happen here? These are the things that we needed, and these are the people we really talked to and got approval from. Because we're also doing an evaluation of this, we had to get institutional review board approval. This is generally speaking a QA/QI project, but we also wanted to study to some small extent how well it's working. So that's why we got AI approval. We had an API. So essentially, you need to have access to a large language model that either runs locally or if it does not run locally, is approved for PHI. It needs to be HIPAA compliant, and you need to be able to safely send information to it. Don't just use your personal GPT. We had permission from the Clinical Intelligence Committee, from the Health Information Technology folks, and we achieved integration within our electronic healthcare record, in our case, Epic. The Division of Clinical Informatics were our first supporters because Alex and I are members of the division. Next slide, please. So let's talk about a few results. Next slide. We have 170 plus unique users. These can be faculty, residents, physician assistants. We have 40 to 70 requests per week, and we have about 30 power users, or actually more than 30 at this point. And it's interesting to see. So for some people, this tool has turned into like a every shift they're on, they click the button multiple times. They request follow-up multiple times, and it's really become an integral piece of their lifelong learning, which is fantastic. On the next slide, you'll see a bit of a graph of how things are progressing. So the weekly requests are, increasing and then slowly steadying up. Our cumulative unique users are increasing. Keep in mind we've got a bit of a hard ceiling here, right? So we exponential growth that we're not the stock market. We can't keep growing forever. We have a limited number of people in the department, so ultimately, unless more people join, we'll hit that ceiling at some point, which we're actually close to. So we're pretty happy to see all those requests, and there's a ton every single day. We keep getting those requests. Next slide, please. So we remember how we have our ability to actually request specific follow-up information. So you click the button, you always get follow-up as a summary. So you kind of can read that, we can make it more concise, more extensive. But a lot of times I have that little question in the back of my mind. Did something happen to the patient? And we're curious, like, what do people care about? So people care, not surprisingly, was I right? Was my diagnosis correct? So people really want to know, did something else come up? Was there any diagnosis that was different? Disposition in 17%. Test or imaging results. Oftentimes you sign out a patient, you admit a patient, and you've got that one test pending that you're like, I ordered that, but I'm really curious what happens, what shows up. And in many cases, there's no like super easy way to follow up on them. So this kind of takes care of this nicely. Treatment procedure that was done, outpatient follow-up. I often care if patients actually follow my advice. Believe it or not, they often do, which is great. Did they come back? The dreaded bounce back, and mortality and survival, though that is also captured in the summary. Next slide, please. So we have been working with a whole bunch of people. This is our, let me brag for a second about how other people like our project. I'll let you read the quote, but we've had success within the department and outside in terms of how well it's received. So our clinical intelligence committee endorsed this, and it allows us to actually grow this within the institution. So we're expanding to internal medicine and anesthesiology at this point, with plans for multiple other departments to grow this into. Our own, bias was obviously for emergency medicine because it is our specialty and a point where we don't get follow-up a ton. And then talking to other departments and the clinical intelligence committee, people were like, well, hold on, we also have that problem. We also send the patient to other places. We also don't always follow up on the patients. So we're rapidly growing the project. We had a podium presentation at the Council of Residency Directors conference, and we've had some internal investments in terms of actually turning this into a larger platform within the university and School of Medicine. Next slide, please. Again, some more quotes about how cool we are. This is basically what we've done is we also tried to get some feedback, right? We need to hear what works and what doesn't work. We selfishly selected the more positive quotes because we all the negative quotes we've tried to like address at this point. But the ones we picked kind of address different topics and themes of why we think everybody should have a project like this. So Jenna, one of our PAs, said this was essential for her lifelong learning. So talking to her a bit more, basically it helps with that activation barrier of following up on patients. Oftentimes you see the patient, you sign a note, and then you never hear about them again. And as Alex said, that dreaded tap on your shoulder, somebody tells you, hey, remember that patient? I don't want to be surprised by that anymore. It's important to follow up myself and do that. Dr. Medlin Rich said it saves him a ton of time. That is a huge motivation for us. Not having to click on the patient, remind myself what the patient's diagnosis was, chief complaint was. It all takes time. It may only seem like 10 minutes per patient, it's not a ton, but honestly, getting that information hand delivered to me makes it just so much easier to follow up on patients. And I review my patients factor of 100 more frequently now than I used to before, and I'm sure others have the same. We asked our residents, Sarah, Dr. Lin here said, it's really popular with the co-residents, and let's be honest, while I might be complaining about my time, the residents have it way worse. They basically work all the time. They have no time for anything. They come on shift, and the last thing they're going to do is follow up on patients from their last shift that they're trying to forget about. So having that like quick learning moment is essential for them. So they've been some of our most ardent users. Dr. Theoni Nick wrote that he really enjoys this as like a use case for AI and also highlights the trainee component of this, which we think is important. Next slide, please. So, summarizing it with this poor guy here, this guy was a patient who had a bradycardia that led to a cardiac arrest, which you'll see as you progress here. And this poor guy had resuscitation in the emergency department. And we were really proud because we actually had a successful resuscitation for him. And if you advance the slide one more time, you can see how it's grayed out because like my field of vision of this patient is I know what happened to him before the emergency department or my care. I know what happened in the emergency department. We resuscitated him, and I felt good enough because like I got him to the hospital. In the back of my mind, though, I know that most patients with a cardiac arrest have a poor outcome. And so for me, it was always like, Well, small success. He has a chance at survival. But unless I would have followed up on him conventionally, I wouldn't have known that. If you move on, you can see kind of the hospital stay, the pacemaker placement, fully recovered, and the feedback loop is closed. I know in this case a positive outcome. So it's valuable in any case to know. And these kind of cases are essential for motivation, essential for calibration of my clinical care. And I was very happy to see that patient recover and do well. Next slide, please. And I'll hand it over back to Alex.
Thanks, Florian. So we want to tell you about where we're going next with this and hopefully get some feedback on what you think the right kind of anchor points might be. So on the one hand, we want to scale our approach across Michigan Medicine. We have support institutionally for that task. And specifically, we're going to work on a focus in graduate medical education. So if you advance just a little bit more, we are in the process of co-designing a user interface that's really focused on specific clinical learning objectives, so very tangibly relevant to resident education. And then if you advance a bit more, the second thing that we're doing is we're trying to leverage the infrastructure that we've built to tackle a specific quality measure. So Michigan Medicine participates in the Michigan Emergency Department Improvement Collaborative, and we report on a quality measure for pulmonary embolism diagnostic practices. And so we think that the infrastructure that we built for artificial intelligence case review might help us with that. Next slide, please. When I think about the House of Medicine, there's all of these handoff points. So in anesthesiology, the handoff point is the transfer to the PACU. So you might spend 8 hours on a really tough case and, have resuscitated a patient numerous times throughout a case. And then you take them to the PACU and, you go back to sleep, hopefully. And similar things happen in internal medicine where a patient is transferred to another service. Maybe they're escalated to the ICU. Patient in psychiatry is seen for an emergency evaluation and then discharged to a really fragile next step. And we are building out the infrastructure to address each of these in partnership with Michigan Medicine. Next slide. If I think about specifically a diagnostic challenge in emergency medicine, pulmonary embolism really rises to the top. So the MEDIC Collaborative has focused its quality reporting on PE for many years now. I think it was one of the first quality measures. And if you advance just a little bit, I'll show you. PE is a uniquely challenging diagnostic situation. On the one hand, overuse of CT scans to look for PE is not just costly, it can be harmful. It increases patients' exposure to ionizing radiation, to incidentalomas and diagnostic misadventures, not to mention gumming up already very busy emergency departments. But misdiagnosis of pulmonary embolism is a very real phenomenon, and the stories of missed PE animate the decision-making processes of emergency physicians all over the country and the world. So on the one hand, strong clinical evidence informs best practices in the evaluation. We don't actually find out in any systematic way whether or not we were right when we thoughtfully defer PE testing in a patient that we think is low risk. So almost every shift I'm writing in a note, I think this patient with chest pain or shortness of breath is very unlikely to have a PE, so I will not pursue testing for that diagnosis today to avoid the problem of overtesting. No one's looking through those cases and telling me later whether or not I got it right. And so our goal is to organize this approach to feedback and learning, really anchored to some of the audit and feedback literature, and use this to tie specific cases to clinical learning points in pursuit of improvement in diagnostic quality by this measure. Next slide. If we zoom out a little bit, this is how we are thinking about this project and what we're doing. We are trying to find the important clinical decision moments, the moments where the decisions that we make as clinicians can have a big impact on a patient's care journey, can be very relevant to the quality of care in the big picture. We're trying to find those decision moments and anchor to them. Downstream of that, we're trying to figure out what matters for patients and how do we access the outcomes of those decision moments? How do we actually translate those two pieces, the moment itself, the downstream outcome, into a story that can come back to the clinician, because those stories are what help us know that what we do matters and help motivate us when we come back into the door the next day. Um, and that's why we're doing all this work. Next slide. So we put up just a few motivating questions. I know we've got a lot of folks from all over the state here, and all of you have your own quality improvement challenges. We'd love to hear about them and have a discussion about them. But these are some of the motivating questions for this group. Where have you had success engaging individual clinicians in quality improvement? When have you used individual clinical stories to leverage that? And, where do you sort of perceive that the feedback loops are broken in your work? And then what pitfalls do you perceive in our work in these applications that we're describing? And as experienced quality leaders in the state, what would you suggest for us as we're breaking into this space? And that's what we have for you. So thank you so much to all of you for your time.
Thank you so much, Alex and Florian, for that lovely presentation. I was fascinated the entire time. I don't have any questions in the chat quite yet, so if anyone would like to unmute and ask a question, you're getting lots of clapping hands. You are welcome to. I think the questions that are also posed on the current slide right now are also really interesting, and we would love to hear, some of you in attendance if you have any responses to these four questions.
I do have one quick question.
Thanks, Jesse.
You had talked about expanding this, scaling this up, and named a couple of different areas where you're looking to. What about in pediatrics? Has this been looked at all for the pediatric ER or any other areas in the pediatric hospital?
It's currently live in the Children's Emergency Services at Mott. We do not yet have a partner within the Department of Pediatrics, but I do think that we're interested in that. We have pretty strong contacts in internal medicine, and this is very scalable. So I think we are actively seeking out folks. If you have suggestions for somebody who might be interested in kind of championing it, I think we'd love to talk to them.
Thank you.
Great. We had a couple. Sorry, Jesse. We did have one question come through, and it's actually one that I was curious about as well, which was, do providers share the learnings that they're receiving, through this feedback loop with others?
Good question.
And kind of what does that structure sort of look like?
Florian, do you want to speak to that?
Sure. So yes and no, right? One of the things that we really care about is that this is a pull, not push kind of method to getting feedback. So I want folks to be able to request feedback and kind of do with that feedback whatever they want. We have formal mechanisms, peer review, M&M, all those other things in order to get feedback on patients where things didn't go smoothly. And I think almost every single shift we sit down, we talk about patients, stuff that was interesting. So there's this big network of informal sharing about patients. Now, we also have methods to like refer our own cases to M&M and other things. And we have talked about having a functionality of like, hey, send this to the service chiefs, the program director, as like this is an interesting learning case that we should share with others. So we actually are in the process of kind of investigating like options for this, where you can kind of save them in your own list, like keep that as a reminder of things that can go well or poorly. And we certainly are in the process of kind of figuring out how to do so without alienating folks. Because what we don't want is to turn this into and it automatically, so anytime it detects anything bad, it automatically copies your boss. And people are going to stop using it, right? I mean, that's our evil robot overlords will have power over us soon enough. Might as well kick the can down the road a little bit before we have them decide if clinical care was good or bad. I think it's important for to maintain that control. But short answer is yes, we want people to have a way to like share this. This perhaps our new application will have like a best of learning kind of thing where people can nominate their cases for crazy stuff that happened. Love that.
I like that idea. All right. We had a comment from Emily Narrator. I think it would be good to connect with Medic and HMS. I know Dr. Janke, you spoke to Medic and the kind of connections here with Medic related metrics. I am curious, there seems to be some agreement there. If there was a particular, HMS metric or initiative, Emily, that you thought this approach might align well with, just to
Yeah,
give us some.
just the central line information. I
Mm,
think that they're interested in that part. So
that
that
makes
would
sense.
be Elizabeth and Dr. Flanders.
Okay.
Yeah, we're happily take the intro and the connections there. So that's wonderful.
Yeah. All right. We had another question. Can you speak to, for those hospitals that are for profit, how would you address the ROI issue?
Yeah, that's a great question. So one of the most natural sort of stakeholders to this work is clinical education, which is why our sort of early funder is the medical school. We think that this tool or tools like this, AI for clinical summary, can become something that helps drive quality improvement and, therefore quality measures and all the stakeholders invested in those spaces. Um, I also, I think Florian and I both believe this really strongly. I mean, we were motivated to do this because it's good for our well-being as clinicians. So I'm sure all of you hear about burnout and moral injury in healthcare all the time too. It is a really important problem in the world, and allowing your frontline staff to have better line of sight on how they make a difference day in and day out is good for clinicians up front. That's number three. Um, and then I think number four is that whether we like it or not, as Florian was saying, this technology is coming for us in some of our other internal infrastructure for case review. So peer review committees pour through lists of triggered cases routinely all over the state, and that work, AI will begin to penetrate that work. And we want to do it in a way that is going to translate into better patient care and helps the frontline clinicians that actually do the care be better day in and day out. And so we really see ourselves as trying to be on the front end of what we think will be a transition in healthcare in many different domains.
Great. Okay, these comments and questions are now flooding in here. So, next question was regarding, do you have any ideas on how this may be used to help prevent inpatient falls?
Yeah, that's a really good question. I like it because it's very tangible. It's very
Mhm.
specific. This is like a really well established problem in the world. So I saw that come up, and Florian, you may have things to add. I was thinking about some of the best practices, things for fall risk, and you folks here almost certainly have more expertise in that space than I do. Um, but there's artifacts of really, really great fall risk prevention in the chart that you could imagine going and finding with artificial intelligence review and then calling those out for your clinicians. So, one would be this is very emergency medicine centric, maybe, but in geriatric emergency medicine, we're very attentive to sedating medications being inappropriately started or resumed at the beginning of a hospital stay. And so that is an example of an intervention relevant to fall risk that you can go find, and you can tell clinicians later that, hey, you went to the effort to do a really careful medication reconciliation. You appropriately identified that that older adult should no longer be on 3 times a day gabapentin, and you did not continue that medication when they came in. great work. That's exactly the kind of work that we want to be doing. That patient did not have a fall while they were in the hospital. And so thinking about what are your clinical learning points? What do you want your frontline folks to be doing? And then telling them when they do a good job by finding those artifacts in the chart. I don't know if you have other things to add, Florian. We of course are not experts in falls, but in hospital falls, but it's definitely relevant to what we do too.
Okay. Great. We had a couple additional questions that I think sort of relate back to our previous discussion about kind of that dissemination and sharing of the learning. So Irene asked, when the patient record is flagged, does that stay in the medical record where it could be
Yes.
discoverable? If not, I could see that as potentially a method for sort of sharing as you have patients that maybe are coming through the ED multiple times, for example, right? Those frequent flyers. And then the second is have you explored ways to summarize what's being learned and then share that without attribution to individuals so that learning can be broader, which I think Florian, you kind of, kind of spoken to a
Yeah.
little bit.
For
Yeah.
the first part, we are very cognizant of the medical legal kind of implications of like, hey, here's a risky case, um, button that you don't wanna snitch on yourself, right? Of like
Mhm.
something that happened, even if you don't think it's risky at all. It's more of a like interesting case. Um, so it actually does not stay in the healthcare record. It's external to that, and I'm not sure if our screenshot showed the extra part of the email, and every piece of communication, every site you're on mentions explicitly that this is a QA/QI thing,
Mm,
which is not discoverable, meaning that is protected by law. Same as like, which is why we have morbidity and mortality conferences, which is why we can openly talk about these things without the lawyers sitting in the corner and taking notes and suing us. It's because of that. So similarly for this, we're very cognizant of that component. And
mhm,
I hope I adequately addressed the second part of the question, in terms of like making it shareable. It's tough, right? You got to make sure that no information is available, and you don't want to have attributed the person taking care of the patient and the patient themselves. So that's what's a tricky part in making it available to anyone outside of this. So we have
mhm.
not yet solved that issue. You're only allowed to see information about your own patients unless it's completely anonymized and de-identified, and we're not at that stage quite yet.
Great. Thank you. All right. We had an additional kind of topic area related to HMS from like a metric or focus area. Sepsis was mentioned as another opportunity, perhaps, to apply this approach. Another question, has this helped with patient grievance investigations? I would guess no, since it's not kind of currently shared in the chart. But if you have other information regarding that, please share.
It is not currently implemented in a way that intersects with patient grievance.
Mhm.
But I do think that we were talking about this earlier too. Like we're rapidly approaching a world where AI will intersect with all these kinds of domains, and so I do think we want to be thinking about how to do that well.
Okay. Adrian asked, do you find providers overuse this tool as a way to just know what happened to a patient out of curiosity versus actual learning? Which I think brings up an interesting point about can curiosity simply be learning?
Yeah.
But
Yeah, it's an interesting question. This came up in our conversations with the Clinical Intelligence Committee as well. So, our perspective is that clinical outcomes downstream of our care that are plausibly attributable to our care decisions um, should be accessible to us as clinicians. So, I do think that it is good and right that your ER doc or PA, whoever you see coming in the door, is curious to know how you did 2 weeks later. That curiosity is important and valuable and humanizing, and it's part of our day-to-day work. Um, what I do in my day-to-day work is take care of patients. I want to know how they did. So what we sort of uh, compromised on was a 2 week look forward period. We sort of said we think that something like 2 weeks is going to be generally, uh, almost always a meaningful time frame for an ER doc's decision making. Um, and there are probably some edge cases where even beyond 2 weeks, it really is important for us to understand how patients did. But that was kind of where we drew the line on that. There's no doubt that there are examples in the world of inappropriate access to patient charts long after we've been involved in a patient's care. I do think that's a really rare event, broadly speaking.
Great. We had a comment from Kathleen. This was sort of related to kind of the previous fall discussion, but I think it speaks to, QI work in general. She notes, last I looked into individual interventions, there's no hard evidence to support any specific intervention is actually decreasing falls. For example, adding a fall alarm or hourly rounding. Yet it seems that bundling interventions and requiring them gets people more focused, and thus you see the intervention, or in this case, falls, decrease. Basically, what you pay attention to, you improve, and when you stop paying attention, the improvements go away. I wonder if you could speak to, sort of how you see this feedback loop sort of mitigating that kind of traditional gap in QI, where it's hard to sometimes hold on to a QI project for a really long time. Hopefully it becomes best practice, but something like fall intervention, for example, is something we got to kind of focus on a lot. And so this feedback loop kind of serving as that occasional reminder is kind of how I'm seeing this come through. Would you agree?
Yeah, I think so. Yeah, I think it speaks to the complexity of the QI problems that I think all of us face. And I think if we're doing this really well, we're using it as a tool to drum up engagement and maintain engagement, certainly. And I think the same could be true of sepsis. In some ways, sepsis has the same problem. Um, this is a perhaps controversial point of view, but uh, we have much better evidence that the bundle matters a lot in sepsis than we have strong experimental evidence for any single intervention. And
Hmm.
so a lot of we don't ourselves do sepsis, but we're close friends with the people who do, and a lot of their work is just drumming up engagement day in, day out, coming up. Hey, what you do matters. No, I can't tell you exactly which part of it really mattered for that patient because we can't run that experiment, but sepsis matters a lot, and that helps us a lot to have that.
Great. Thank you. All right. These last two questions are kind of speaking back to handoffs and sharing of this information provider to and provider, specifically ED to ED provider handoffs. Um, and I think you kind of spoke to this before, but do you want to add anything to uh, the ways this might help strengthen provider to provider communication outside of, kind of that personal learning component?
Yeah, actually, Florian and I were building um, basically an option into the next generation workflow to CC other docs. This came up a lot in conversation with the Department of Internal Medicine.
Mhm.
Um, I'm not sure we have all the kinks on that totally figured out technically or in the user-facing
Mhm.
approach, but we do think that would be a really powerful tool. As an example, so I hit the button on almost every patient I see in the ED, and then I use it to help me when I send a follow-up to the residents. Because it
Okay.
helps, because then I have the list of patients in front of me. I know what happened to them. I send the residents an email follow-up and I say, oh, hey, this urine culture grew Enterococcus fecalis. That patient never had symptoms. That was colonization. Now you know in your head what that patient looks like. And so I'm using it as a tool to carry me into a conversation with my residents.
Great. All right. Well, just with an eye on time, if there's any additional questions that someone wants to ask out loud, we can probably take maybe one more, and then we will close out the work group for today. So just a couple of MVC reminders. Any last minute questions?
Hey, this is Irene.
Hi, Irene.
I had one last minute question I thought of with the education sometimes being a struggle to get people to do it because we're trying to use this as training. Can CEUs or education for providers be accrued in this process to try to help with that encouragement for signing up for it?
Yeah, that's a great idea. Um,
That
that's a really good
I
idea.
don't think we thought about this yet.
Yeah.
Oh, tremendous. Yeah. All right, somebody email us, help us do it.
Well, I don't have any ideas there. I was just thinking, our struggle is to get people to participate with the
Yeah.
education that we
Oh,
provide.
Yes.
that's
And
clever.
you dangle that carrot, sometimes it helps.
Yep.
I love
Yeah.
that idea, Irene.
And if you can say, hey, I need you to think about this PEQI measure that we're doing. Remember that patient you saw a week ago? And then maybe they're listening just a little more. So this has been a great conversation. We are so appreciative of all of you for listening in and for lending your thoughts on this.
Well, thank you so much, Dr. Janke and Dr. Schmitzberger, again for presenting and engaging us in that great discussion. I think we all got a lot out of that. I just had a comment. This has been one of my favorite work groups. Thank you for sharing. So that's lovely to hear. All right.
Thanks so much for having us.
Yeah, no problem. A couple of quick reminders here. We're looking forward to our July work groups. Our next two work groups are going to feature a rural health work group with a presentation from My Michigan on their system-wide sepsis post-discharge follow-up program, and specifically how they implement this in a rural health setting. And then later in July, we'll host our post-discharge follow-up work group. So lots of post-discharge follow-up in July, if that's your area of focus. And that second work group will be a review of MVC's recent follow-up push report, which will cover both site level and health system level reporting. If you miss any work groups or specifically missed work groups from last month, remember that we do share our blog summaries at the beginning of each month. So feel free to go back, listen to recordings of our work groups if you'd like to reference those presentations. And then my last few reminders here are that MVC's QI survey is due on June 30th if you would like P4P credit for completing that survey. If you have any questions, feel free to reach out to us about that. And then additionally, our fall collaborative wide meeting presentation proposal submissions are due July 28th. So end of this month. If you are considering and interested in presenting a breakout, a round table, a poster, a main session, please get us those presentation proposals, and we'll be in touch with reminders regarding that throughout the month. All right. That concludes our Health and Action work group for June. Thank you so much for joining me, and we look forward to seeing you in July.